Okay, we are going to move on to our next presenter, who is Dr. Jean Bonhomme. Dr. Bonhomme earned an MD from State University of New York at Stony Brook, and in 1987 he founded the National Black Men's Health Network. For decades he's been recognized as an expert on minority men's health, and he's a professor at Morehouse School of Medicine.
Okay, good afternoon, everyone. As we've discussed, the overall U.S. life expectancy, while lagging behind a lot of other countries, there's currently a gender difference between males and females of about 5 years. It was a little smaller than that a few years ago. For white males and white females, the gender difference is 4.9 years. For black females and black males, it's 6.1 years. Now, one of the questions that's been raised recently, Dr. David Sinclair at Harvard is asking if there really is a limit to human life expectancy. We don't know. For that reason, we don't really know whether the gender differences really represent a limit to life expectancy. One of the things that has happened that has lowered mortality, for instance, for men with prostate cancer, the mortality rate decreased from 39% from 1991 to 2008. Now, one of the things about prostate cancer is that it rarely has any symptoms in the early stages. Urologists who I work with talked about in the 1980s when he got started, the typical way that prostate cancer would be detected would be a man would come in with a severe backache, and by that time it will have already spread to the spine and would be basically untreatable, except palliatively. When the PSA, prostate-specific antigen test, was introduced in 1991 to 1992, it is not specific for cancer. It can be high because of an infection. It can be high because of enlarged prostate, but the fact is it gives it an early warning. There has been some debate about whether it should be used routinely, but the fact is that it is felt that it did have an impact. Another thing that had an impact, according to this researcher, Ruth Stoney at HHS, is that improved treatment has also been a factor there. Now we have, in addition to things like radiation and surgery, there's cryotherapy where they can freeze a tumor. There's a high-intensity focused ultrasound where they can use ultrasound to burn a tumor. So the point is that we have better treatment than before. So the prostate cancer mortality has been declining owing to screening and treatment. Now, cardiovascular disease had been declining steeply, 3.5% to 4.5% yearly until 2014, but then afterwards it started to go down by less than 1% per year, but it had been going down 3.5% to 4.5% per year. Cancer had been steady going down and is continuing to go down, the mortality rate at about 1.5% per year. But the slowing of the decline in cardiovascular disease, for some reason, it's occurred in males, females, all races and ethnicity groups. Males have had higher mortality rates for females for both heart disease and cancer. Non-Hispanic blacks having the highest mortality for cardiovascular disease and heart disease in all years, followed by non-Hispanic whites, non-Hispanic American, Indian, Alaskan Natives, Hispanics, and finally non-Hispanic Asian Pacific Islanders. And again, the rate of decline of cancer mortality has remained relatively stable. The opioid epidemic. I worked in drug treatment for about 35 years, and basically it has now been compared to the AIDS epidemic of the 1980s. I think very few people here are old enough to remember that, but it was a really terrifying thing when we had a disease that we didn't know how to detect, and people were dying from it. We didn't know who had it until testing was invented, and then for a long time we couldn't treat it adequately. But annually, more people die from overdoses, primarily opioid drugs, than died in the entire Vietnam War, the Korean War, or any armed conflict since the end of World War II. It's estimated that 90 Americans died daily from an opioid overdose. From 1999 to 2011, the mortality rate of opioid-related overdose increased almost fourfold, and the rates of emergency room visits increased by more than 200%. Neonatal abstinence syndrome is babies being born addicted, and opioid use disorder treatment admissions have also increased greatly. Death rates are highest among males under age 50. In Massachusetts, men aged 18 to 34 had opioid-related deaths rates nearly 3 times that of women of the same age. Most people who reported prescription opioid misuse initiated the use in the early to late 20s. Overdose deaths can be misclassified. Sometimes we tend to classify them as accidents, but sometimes there's suicidal intent that we don't know about, especially in older adults. And it's further complicated by the increased availability of heroin. Around 2000, prescription pain pills took the opioid market away from heroin, but now heroin is cheaper. And in treating drug addicts, I would often find that they were using the heroin because they could get it easier than they could get the prescription pain pills. Another factor that's come on that these researchers were not able to consider is that now we have the opioid analogs like fentanyl. They can be made in labs, and sometimes we have fake pain pills that fentanyl has a potency about 80 times that of morphine. So if it's not cut precisely, even seasoned addicts can die of a fentanyl overdose. And about 80% of current heroin users reported that they began with prescription opioids, and that's consistent with my experience in drug treatment. A lot of people who never used drugs or never smoked developed a pain condition, whether it was from an auto accident or whether some women had endometriosis and had severe pain. So one patient had a melanoma removed and was left with a severe scar that was painful, but they may start with prescription opioids and then be unable to get off. So a lot of it begins with prescription opioids. When you see a person addicted to opioids, it's not necessarily that they became addicted recreationally. They may have become addicted because they had a painful condition and they were left on it too long without being tapered. 200% increase in opioid-involved overdoses took place from 2000 to 2014, according to Rudd, and a 3-fold increase in heroin-involved overdose deaths from 2010 to 2014. Now, U.S. suicide rates. The suicide rate has increased 33% from 1999 to 2017. It was originally 10.5 to 14, and increased to 14 suicides per 100,000. And from 2000 to 2016, for white Americans, 11.29 to 15.7, and from 5.52 to 6.03 for black Americans. Now, black Americans are typically thought of as having a greater homicide rate but a lower suicide rate. But one of the things about suicide in black Americans is it typically involves younger people. The usual demographic for someone who commits suicide would be an elderly or middle-aged male who might be in poor health, might be isolated. With African Americans, it tends to be the younger men who are taking their lives. Suicide is the 4th leading cause of death for people aged 35 to 54, the 2nd for 10 to 34-year-olds, and it's the 10th leading cause of death overall. What are the risk factors that predispose to suicide? Depression, substance use disorders, mental illness, poor physical health, chronic pain. The means of suicide, if you have access to a means that's very lethal, guns and ropes tend to lead to suicides that are completed, where overdoses might not. Divorce, unemployment, relationship problems, finances, previous suicide attempts, family history of suicide, and a history of childhood abuse or trauma are risk factors for suicidal behavior. And suicide rates tend to fall when socioeconomic conditions improve. They said that Ann Case and Angus Deaton have found that deaths from suicide, drugs, alcohol have risen steeply among white middle-aged Americans since 2000. They seem to be being displaced, especially the ones without college degrees. They seem to be displaced in the employment market. And they call those the deaths of despair. And suicides have increased most in rural communities because of loss of farming and manufacturing jobs, with resulting economic declines over the past 25 years. So we've made progress in certain areas. We have less cancer deaths. We have less cardiovascular disease deaths, which are the two leading causes. However, we've had other things coming up with in terms of suicide and the opioid crisis. Now, the gap in life expectancy between the genders has not been fixed. In 1920, it was only 1 year, and then it gradually widened. About 1970 to 1980, it became its widest, and now it stands at 5 years. Now, people ask about, why is it that women outlive men? It might be a better question to ask, why did the increase in life expectancy that took place over the course of the 20th century for men, why did it not keep pace with the increase for women? Did we do something differently? Is our outreach, is our intervention different? We need to consider that, because it appears to fluctuate. This slide I found really compelling, and it's really surprising to me, because if you look at this is the excess mortality in males by age. It is greatest in the 15 to 24-year age group. Now, if the difference in life expectancy between the genders is innate and biological, why is it the lowest in infancy and old age, where you would expect biological effects to be the greatest? The frail elderly and the infant is biologically more vulnerable than the 15 to 24-year age group, where we get our Olympic athletes from. The fact is, what's causing the deaths is something that probably doesn't have that much to do with biology: injuries, suicide, drug overdoses, things of that nature. But these are things that we can potentially change. A study that's available online, David Sandman, Out of Touch American Men in the Healthcare System, found that men in the 18 to 29-year age group were the least likely group to have seen a doctor in the past year or have a physician. I was talking to some women professors at Morehouse School of Medicine, and they offered to me that as girls they were treated by the pediatrician, but as soon as they became old enough to be considered women, they were given to the OBGYN, the gynecologist, for continued care. For young men, the health care drops off the face of the earth once they get past the pediatric age group, which is a shame, because in the 20 to 29-year age group, we have hypertension and prehypertension, we have high cholesterol, we have diabetes and prediabetes, we have overweight and obesity. And when men start seeing the doctors more in their 40s, 50s, and 60s, but if you've been sick with high cholesterol, with high blood sugar, with high blood pressure for decades before you see a doctor, the prognosis is very different, because there's already been significant end organ damage. So the point is that boys not being connected to the healthcare system in the 18 to 29-year age group is an area that we need to rectify. And some people say that we need to try sports medicine or some other way to continue health care for males after the pediatric age group. Also, men are taught to be stoic. When a boy is 8 years old and he skins his knee, they tell him brave boys don't cry. When he gets hurt playing high school football, they say take one for the team. When he's 50 having chest pain, he says, oh, that's just indigestion, because he's been taught to ignore his body. So less than 20% of males stated that if they were in pain or sick, they would seek help promptly. 24% said they would delay as long as possible. 17% said they would delay a week or more. So the point is that we need to look, men are more performance-driven. If you tell them this will make you work better, this will make you more attractive, this will make you stronger, if healthcare is marketed to men as something that improves performance, it'll probably be more attractive to men. Now why have men's health in the first place? We need to consider the effect on spouses and children. My next door neighbor called me in 2002, unable to wake her husband, and I went to see him, and he seemed to be conscious but unable to speak or coordinate his movements. Turns out he had a stroke, and he had signs of it months before that were not picked up. But she lost her companion of 32 years. If he had survived a stroke, she would have had to care for him the rest of her life. When a man becomes disabled, who has to take care of him? Her earnings are diminished. She has trouble affording her house. A woman who loses her husband, her all-causes death rate doubles in the month after. So, and older women don't typically have good prospects for remarriage, and in disability, a family may face increased health care expense in the face of diminished earnings. So you have less money but more costs. And the economic effects on society of male illness and death: lost time from work, diminished work productivity, a provider may become a dependent, a taxpayer may drain the tax system. You may be not quite disabled, but have difficulty maintaining gainful employment. I worked with a physician with rheumatoid arthritis. When he got up in the morning, he was so stiff he couldn't come in and see the patients until he had worked his joints, and that's typical of arthritis. So the point is that you might not be, you're not exactly disabled, but your ability to work is limited. Poverty is associated with widowhood. Children face these repercussions as well. The way I feel about men's health and women's health is that you can't effectively weed half a garden. You have to treat all of the garden or the weeds will just grow back. And some people think that men's health and women's health are like opposite ends of a seesaw, that if you give to one, you have to take away from the other. I think exactly the opposite is true. I think if you don't address both, you can't fully address either, because the genders are interactive and interrelated. So men's health is a vital but often overlooked aspect of community health. Our rising tide lifts all boats, so if we pay more attention to men's health, we can improve the health of both genders and achieve optimal overall health in our communities and in the nation as a whole. We need to look at a tetrad approach between co-equal partners, children's health, women's health, men's health, and minority health being all addressed so we can optimize health everywhere. Thank you.